Well, thank you very much for the invitation. It's very humbling and also exciting for me to present this work in a public health audience, and to also hear about all the wonderful work going on, which is more focused on the response of the body to infection and immunity. Whereas what I'd like to talk about is the physical process by which a pathogen is actually transferred from one person to another, which I believe really does need to have input from the physical sciences and engineering. And so I hope that part of what we gain from this interaction is that stronger connection between physical sciences and the medical sciences, actually. So first, I have to show you a slide, which is actually a very serious slide. It's a little bit tongue-in-cheek, but I'm giving you a warning that what I'm about to tell you is medical misinformation as currently still defined by YouTube and in fact, many other platforms that regulate and censor content based on the following definition: that medical misinformation is anything that contradicts local health authorities. In particular, on these topics, which I will be discussing: social distancing, prevention, transmission, et cetera. And then ironically, there's a footnote that says the policy is subject to change if the local health authorities change their guidance. So I used to think that truth was an absolute notion, at least in science, we're sort of chasing after that. But now I guess truth is defined by authorities and whatever they happen to tell you at that time. Of course, none of us believe that as scientists. And so I feel the statement at the bottom is extremely important. I hope you all will help me in advocating to really fix this problem, which I see as a major cultural problem today and a very dangerous trend. Science and democracy depend on skepticism of authorities and also open debate of misinformation. Every scientific discovery at some point started as misinformation contradicting local authorities. That's true of the round Earth, the Earth going around the sun, et cetera, et cetera, et cetera. The atomic nature of matter versus continuum, those were all radical ideas at some point. We must allow open discussion. And frankly, censorship is immoral and it's certainly counterproductive. And I think COVID-19 has showed us that so clearly on this topic of transmission itself, which is, you could argue, is one of the most fundamental aspects of organizing a public health response to any epidemic. So here are just some of the headlines. You're probably very familiar with them, but I just want to point out that certain aerosol scientists, such as Bill Ristenpart, a chemical engineer at UC Davis, and Lydia Moravska, who's been working in this field for a very long time, making huge contributions, already at the very beginning of the pandemic were pointing out there could be airborne spread of this disease carried by aerosol particles. And in fact, Moravska went so far in the title of one of her papers saying the world should face reality. Unfortunately, a year went by and the world really didn't face reality as far as at least the public health guidance, despite the fact that those scientists and others really mounted a campaign of trying to get this word out. So you may be familiar, there was an open letter with hundreds of signatures. I would gladly have signed that at the time myself, that was covered by the New York Times last summer. The CDC finally posted some guidance that airborne transmission might be happening in September. Then they took it down. Then they put it back, but saying that it's probably not that important. And now finally in May, essentially they've acknowledged that it's the dominant mode of transmission, which many other scientists, including myself, have thought for most of the time. So I put here this statement, can local health authorities themselves unwittingly spread misinformation if they are the ones that define misinformation? Okay, so enough about that. But once you begin to acknowledge different modes of transmission and the physics behind it, you can ask the question, how should public health guidance respond to that? And that's really been the question that's motivated me. As a disclaimer, I should tell you that I am a physical scientist and engineer. Most of my work is in fields such as fluid mechanics, electrochemistry, and other areas of engineering. And I became interested in this problem, frankly, when MIT started talking about the 6-foot rule and took laboratories that have very high air change rates that already deal with airborne pathogens and started putting stickers on the floor 6 feet apart. And so I started thinking about the physics of transmission and realized that there might be a little bit more going on here. So with that background, let me just tell you a little bit about the modeling approach that I've pursued and many others have also pursued, and then tell you a bit more about how I believe COVID-19 is primarily spread and how we can defend against it. So the starting point to think about airborne transmission is the so-called Wells-Riley model. In this audience, many of you may be familiar. Actually, when I started, I didn't know about that. I just wrote down the same equations myself because it's essentially undergraduate chemical engineering. We call it a continuous stirred tank reactor. If you have a room or a volume where there's some production of some chemical and there's a removal of that chemical by, let's say, exchange of that air, then a simple mass balance tells you, what is the rate of buildup and steady state concentration of that chemical. Here, we're speaking of virions that are contained in exhaled droplets from the breathing of an infected person. And so we can go into some detail to describe the production rate. And actually where my work has differed a bit from the previous work is in really looking closely at the size dependence of droplet production from different respiratory activities, and also in sedimentation of those droplets and filtration and deactivation of those droplets as well. In any case, we can make estimates of those sorts of processes and finally arrive at a transmission rate, which comes from integrating over all the different droplet sizes, and includes factors such as the mean breathing rate in the room, QB, the mask effective penetration factor, so what's the sort of filtration efficiency of masks that if they're worn, and then all the different decay rates that come in for removing the virus, the volume of the room, and one disease parameter, which I like to express as the infectiousness of the exhaled air, or the infection quanta per volume of exhaled air. And as I mentioned, many other people, including all the names here and others, have proposed similar models for COVID-19 and have even produced some spreadsheets. What has distinguished my work is really trying to go past these equations and simulations or spreadsheets and to get to something as simple as possible, but not too simple. So something to augment this something as simple as the 6-foot rule. So I'd like to get to a formula that really shows the dependence on the different variables and allows you to then guide decision making. And so that's what I'd like to present. Before I get to that, I just want to mention that there have been some studies with simulations and also some experiments I'm aware that are underway, looking more closely at this assumption of a well-mixed room, which underlies the Wells-Riley model. Here is a simulation that was published recently from Mike Kinzel's group at University of Central Florida, where they simulated a classroom. You can see here the puffing of the breathing of each of the people in this room. There's one infected person in the second row, and those are the red particles being emitted. You might wonder, why are they rising up? Aren't they supposed to be blasted right at the neighbors' faces? Well, not quite, because actually warm air tends to rise. So we're going to come back to that later in this talk, but the air around you does tend to rise, and especially if masks are worn, which really prevents the momentum of the fluid to be imparted by the breath, you will tend to see it rise, and then it actually becomes mixed by the natural air currents in the room. And as shown in this simulation, if you compare with people sitting at 1 meter or 6 feet or further, there's almost no dependence on distance in the ultimate sort of inhalation over time of those particles by people that are at least some distance away. So let's just take 1 meter as a somewhat arbitrary number. So that's at least some evidence that these kinds of models are useful. I should mention that in the field of building engineering and also indoor health of buildings, the concept of a well-mixed room is a starting point for all modeling that goes back many decades, not only for disease, but for other types of calculations, for example, of the energy cost to optimize ventilation systems for humidity and temperature, et cetera. So it's a reasonably well-validated concept, not to say that there aren't departures from well-mixedness, as we see in this simulation even, but certainly it's a good starting point. And if you want a universal guideline, I would argue it's actually really the only starting point, frankly, because you would need to otherwise know some details of each specific case. Again, for this audience, this may not be necessary, but let me go over the production of droplets from respiration and knowing that those droplets may contain pathogens such as the virions of SARS-CoV-2. So here is a plot of the measured droplet size distribution from a person who is speaking from work of Lydia Moravska's group, 2009 in this case. And there have been other studies showing similar results. And what they identified in that study was basically there are 3 different modes of production of droplets. The smallest droplets, which are really true aerosols at the 1 micron scale, are believed to come from the deepest parts of the lungs, from basically the collapse and reopening of bronchioles and alveoli, where the mucus films that are present are brought together, stretched out, and as the air is passing by, are aerosolized, and the fluid is spread out into the exhaled air. There's also something that we've become much more aware of during COVID-19 is the importance of production of droplets in the larynx. And this is a fluid mechanics problem, which actually I do hope to study at some point soon, which I don't believe there's a very detailed literature on. But here's a movie of a person who's speaking regular speed and now slowed down, showing the vocal folds, slapping against each other. This is not an infected patient. And you can see there's plenty of fluid there, airway mucus and other various fluids that could be infected. And as you see, the surfaces come together, they stretch apart, the air is rushing by, and you can release lots of droplets that again are in the aerosol range, perhaps a little bit larger. There's also been recent work from Howard Stone at Princeton in engineering, who's been studying the release of droplets during speech. And again, this looks like somebody who is spitting, but it's not. It's somebody who's just simply talking. And you may not realize that when you're talking, every time a liquid covered surface comes into contact with another one and pulls apart in the presence of a crossflow, you stretch apart that liquid film and you eject droplets. But the speech mode that is especially strong when you're speaking plosive consonants like P, those lead to larger droplets. We can see them in this video, and they're at the scale of sort of 10 or 100 nanometers. So they may also be carrying an infectious disease. But on the other hand, they're bigger, they settle faster, they don't reach the deepest parts of the respiratory tract of another person. And I believe also for other reasons may be less infectious, because it's common in chemical engineering to realize that nanoparticles, nanodroplets are typically much more reactive because they have very high surface to volume ratio. And so let's say if there's a pathogen inside a very small droplet, it's much easier to get out. If it has high surface area, it is very small. So there's many reasons to believe actually physically that in fact we should be worrying a lot about these aerosol drops. Okay. What I did with my colleague John Bush, I should have mentioned, in analyzing some data for spreading of COVID, was to take the model I showed earlier and start with the droplet distributions measured by Moravska and also by a different group of Bill Rissenpart for different respiratory activities, and then simulate what would happen to those droplet distributions in various indoor spaces, and then apply the results of the model to interpret observe super spreading events. So for example, if we look at the famous Skagit Valley Chorale, which was a choir practice in Washington State, one of the first super spreading incidents in the US, perhaps the first, last March, there was a 2-hour choir practice and one person infected 53 out of 61 others. They were not within 6 feet of each other. It was later verified. And obviously it's not even really possible that they could have all sort of touched each other. And yet this spreading occurred, leading to several deaths, in fact. So if we look at that case and we simulate what would be the droplet distributions in singing, or if hypothetically they were engaging in other activities like speaking or breathing through the nose or mouth, you can see here the volume distribution of those infectious droplets. And you can see it's a very large volume, especially for singing, right around the scale of a few microns, which is going to be very important for spread of disease. So that's actually one of the main data sets we looked at, as have other groups, and I'll come to that in a moment. Also, I, at the time, just went around and tried to find any data I could on spreading and try to make sense of it, including here's a transmission on the Diamond Princess cruise ship, and looked at a number of different cases. And in fact, one message I'd like to send to public health is when you observe a spreading event or do contact tracing, don't just write down who got infected. Tell me who didn't get infected, how long were they together, and what were some physical characteristics of the space? How big was the room? Some estimate of, is there any ventilation? Was a window open? If we had a large data set like that, where we had those numbers actually recorded, we could make so much progress on this problem. The challenge is it's impossible almost to find any spreading events that have been carefully analyzed enough to make the case. In any case, from this analysis, I started with the Skagit Valley Choir and also made sure it was in fact consistent, what I found with a published work of Miller et al., which I should have cited here, also working with Moravska and others. And if we just rescale based on the distributions that we would expect in that space, for different types of speech, or different types of respiration, I should say. And we also add onto this the work of Ristenpark's group, which also measured distributions of droplets for different respiratory activities. We come to a surprisingly consistent inference for the infectiousness of the exhaled air. So the singing is way off to the right in this diagram at around 1,000 quanta per meter cubed of exhaled air. But if we look at other examples here, and by the way, I calibrated the two data sets by saying that for intermediate speech, or in Ristenpark's analysis, and what was called voiced counting in Morofsky's experiments, we'll say that's the same number. Then we get pretty consistent range of estimates going from 1 to 10 quanta per meter cube for sort of resting breathing through the nose or even through the mouth, and then ultimately speech increasing with volume of speech pretty significantly, and ultimately singing being the highest. We also have estimates on here from some other cases. So I mentioned the Diamond Princess. Actually is a very nice example of a bus ride in Ningbo, China early on, where one person infected about 23 others out of a bus carrying, I think, 68. There was no correlation with distance in seating on the bus from the infected person, and yet we could back out of that analysis a infection quanta number that is pretty similar to these other estimates. Yes, so that's I think one important point. Also, when thinking of a guideline for protecting against spreading, it's important to mention these super spreading events that we've looked at mostly involve the elderly, likely patients that were at high or peak viral load, so that obviously a lot of spreading occurred. And also the analysis assumes that all the spreading was due to airborne. So we're overestimating that part if there were maybe other modes of spreading, for example, through fomites or other sources. So I think when you use these numbers, you're being fairly conservative. And so I'd like to, proceed with that. One other point I'd like to make down here is that I think many scientists would agree on the kinds of numbers I'm showing here for infection quanta per meter cubed or per time being released by an infected person breathing. Where we may disagree is in how infectious a single virion is, because we don't actually know the viral load and we don't know exactly which droplets are most infectious. In my opinion, it is mainly those aerosol droplets. So there's a lot of virions that are in larger droplets. They carry a huge volume, but I don't think those are the ones that are primarily causing infection. And if I run an estimate based on viral loads in only those aerosol range droplets, I arrive at a number on order of tens of virions that are required to cause infection, which makes it about 10 times worse than the original SARS, which kind of makes sense because we now have a pandemic and we didn't 20 years ago. Nevertheless, we can debate exactly how infectious a virion is, and that's probably almost impossible to measure. But what is more clear, though, again, is this notion of infection quanta introduced by Wells. And the rough numbers here, I think, are quite reasonable. And the important thing is the huge dependence on respiratory activity. So now we come to the main point of the study, which was to derive a formula. And so here you have it, which basically tells you that any attempt to bound a single variable, such as the number of people in the room, the spacing between the people, the ventilation rate, time, all of those in some sense are doomed to failure because those variables are inevitably linked. So as I said, I wanted to derive a formula that was simple, but not too simple. And most of the public health guidance, I would say, has been too simple. Now, I understand the need to kind of make rules easy to understand and therefore easy to follow. So I definitely get that, and I don't mean to be critical. But I think it's worth recognizing, though, that airborne transmission really does involve a coupling of some key variables. So the first thing is you couple occupancy and time. So this here is an analysis based on controlling what I call the indoor reproductive number. That is based on the assumption that an infected person has entered and every other person is susceptible. So this does not account for vaccination or other forms of immunity, et cetera. So it's kind of like the most conservative. But what you see is you get a bound not on the number, not on the time, but on the product, because the more time you spend in the space, the more chance there is of transmission. And it's a similar effect as having more people in the space. And so the bound on occupancy and time, that product, which is I call the cumulative exposure time, is the right-hand side of this equation. And a plot, and the curve is actually hyperbola. That's this blue function here. If number times time is less than a constant, that's a hyperbola. and it's this shape here. And as you can see, if you pick any occupancy at a certain time, it becomes unsafe, okay? Now, how do you make the room more safe? By moving that blue curve up and to the right. That's the bound on the right-hand side of this equation. So it's somewhat obvious perhaps, but we can increase the volume of the room. It dilutes the concentrations more. We can increase the ventilation rate. So that's the rate of exchange of outdoor or fresh air. We can improve filtration of the air by either in the ducts or through freestanding units. We can try to manipulate the natural deactivation rate of the virus, which does depend on relative humidity, or by ultraviolet or other, or maybe cold plasma or other treatments one could put into the room. The ceiling height matters because tall ceilings, it takes again, helps with sort of the dilution. Now, on the other hand, we also can decrease the mass penetration factor, which is a way of saying that masks are more effective in filtering. We can decrease our breathing rates. We can also decrease the CQ I just was speaking about, which is, refrain from singing and ideally try to keep our mouths closed and breathe in a restful way. We can also look at the relative susceptibility compared to the baseline cases that I used to get the numbers on the last slide, which were for mainly elderly super spreading events of the original strain of SARS-CoV-2. So if we look at, say, the UK strain, which is estimated to be 50 or 60% more transmissive, we can certainly put that in. Also, I believe that we can argue that children are less likely to transmit, maybe by a factor of 4, but we can debate, different ways of looking at that in literature. But we put all that together, and then we can start to make quantitative comparisons of different situations and also different mitigation strategies. So we find that wearing masks is a very effective way, as you might imagine, to limit the spread of airborne disease. Increasing ventilation is very valuable, as is filtering air, although maybe not quite as much. I should say it depends also on the type of air you have outside. So if it's hot and humid or cold and dry outside, it's obviously much more energy cost and more difficult to produce that increased ventilation or filtration, and that's something I'm actually also working on now. But anyway, this is the formula, and I also wanted to mention there's in order to make this more accessible to people, we've created an online app which you can access with your cell phone or your laptop, where you can, in basic mode, play around with the predictions with just sort of very generic kind of preset behavior. You can also go into advanced mode and really set some of the numbers if you think you know them, and also get outputs such as carbon dioxide monitoring levels, which I will come to in a moment. But let me first illustrate just some examples of what kinds of predictions are possible, with the theory. So if we look at occupancy versus time, let's say for a typical classroom in the United States, we ran some kind of average numbers here. We see there's a significant effect of ventilation. So if we have the windows closed and no forced change of air, typically rooms will still exchange air on the rate of several hours. That's, by the way, necessary. Otherwise, we would suffocate. So every room has to be designed to have some exchange with the outdoor air, simply to survive in that space. But that's usually a pretty low rate if all the windows are closed and there's no ventilation. And so you can see, for example, if no masks are worn in this classroom example, even with poor fitting masks, actually, I'll come to in a moment, you can see that without mask, you may be only safe for an hour, even before you might expect a transmission to happen. And that isn't even that sensitive to how many people in the room. But if you increase ventilation, you might change that to a full day. Maybe you get 8 hours in this example. And if you wear masks, on the top, you see the time is now switched to days, and that's of cumulative time. So you might get several days, like say 48 or 72 hours of time. That might be a full week or more of class time, which is great, because during that time, either a person might begin to recover or be removed by symptoms or by testing. At MIT, we test once a week. To me, a validation of this prediction, which I've been making actually since last summer, is that especially at universities such as MIT, we know, looking at the data, that transmissions on campus are exceedingly rare, even during the pandemic. And some universities, such as the University of Illinois, never closed down. 26,000 students tested every 3 days, but never closed down. And they were mainly finding few transmissions on campus and more off campus, where people, of course, are less careful. They're sharing indoor air in their homes and other spaces, et cetera. On the other hand, if we look at, say, a nursing home example, And here is a typical nursing home in New York City, by the way, where the official occupancy limit might be 3 or even 2, depending on the size of the room. There we see that if we take a also lower risk tolerance, that we may find an unsafe situation in a matter of 15, 20 minutes because of the proximity. And here is where that public health guidance can really be very misleading, even with deadly consequences, because if you're 6 feet or let's say 8 feet apart with those beds and you're disinfecting every surface every 20 minutes, you're not protecting against the danger of people that are sitting there sharing that air for long periods of time. And we all know what happened in New York City. And in fact, globally, my understanding is that about 1/3 of the deaths have occurred in elderly care facilities. So I think this is a very important piece of information to be aware of.
A couple-minute warning.
Oh, sorry, how many minutes?
A couple of minutes.
Oh, sure. Thank you. I'm basically wrapping up. I wanted to take here a picture from a nice FAQ page that's maintained by Jose Jimenez, just to point out that, as you can see from the analogy of smoking, what I've been talking about here is really the risk of secondhand smoke, which is the diluted air in the background in a well-mixed room where social distancing wouldn't really be particularly helpful, and time is extremely important to control, as opposed to short-range transmission from direct exposure to someone else's respiration, where social distancing does help, and masks can also be very helpful to block that, as I mentioned earlier. I'll just briefly mention here that we also have extended the guideline to take into account the theory of turbulent plumes, so that if you really are just standing directly in the way of somebody's respiration, it turns out the decay of concentration is 1 over distance and can be in fact calculated fairly accurately. And we can include that correction factor in our analysis if you know on average how close people are and how much they're facing each other. I also wanted to show here this little movie of what happens just when people are breathing normally. Just the warmth of your body causes the air to rise. And if you're not coughing or speaking, with plosive consonants, you're not really pushing the air that far out. There's this man breathing through his nose, and you see just a little respiratory plume, and then it starts to rise again, and it gets swept away in the currents and contributes mainly to airborne transmission in the well-mixed room. And masks, of course, as shown in this picture, hold the air even closer. It may leak out the sides, but you again lose that momentum to your neighbors, which well before 6 feet, the air is not really going to be pushed, that far. We can use the guideline I showed you also to take into account the probability of transmission, the total probability, including the chance there is an infected person or there's a susceptible person. Today, that probability is now exceedingly low given the prevalence and vaccination rates. But if you look back, a few months, you could progress through a situation from the guideline is telling you to reduce occupancy and time in that space to having full occupancy with masks. And eventually, depending on these respiratory jets and that distance estimate, we could tell you exactly when you might be comfortable relaxing even distancing requirements. The last thing I just wanted to mention briefly is that a very clever way of getting a proxy for infection transmission risk, respiratory transmission risk, was introduced by Rudnick and Milton in 2003, which is to monitor carbon dioxide. And that as a proxy for indoor risk. Now, what it does is it basically lumps some of the variables we don't know, like the ventilation rate and the breathing rate of the people, especially, and those things can vary in time. And so we can take our guideline and cast it as a bound on safe CO2 concentration. And I again wanted to mention the effects of masks, filtration, and time, because masks and filtration affect droplets, but not CO2. And also the effect of prevalence. So depending on whether you're really enforcing a control of the reproductive number in that room, where you're assuming someone has arrived and everyone is susceptible, versus later in the pandemic, like now, where you might actually consider how likely that is to happen. And the bottom line here is that whatever level you pick, let's say, by the way, 400 is the typical number for the background, and 40,000 is what's coming out of your breath. Some people have advocated, for example, for 700 as a bound. I think that's a great number to keep. But the actual risk, may give you may get plenty of time and might be able to handle slightly higher levels in some cases, or in other cases lower. So I just wanted to point that out. Last slide. We have done monitoring of CO2 at MIT in our classrooms and our offices. and have a formula basically directly relating the time series of CO2 to the instantaneous time series of infection transmission risk. So we can actually take real data and plot, an estimate of what is the transmission risk in that room. And we can see, for example, in a small office, if people aren't wearing masks and we're enforcing the reproductive number, then we might expect to see transmissions in a short time. On the other hand, our classrooms, it turns out, are so modern, so well ventilated, that we are finding that even without masks, actually the transmission risk is pretty low, actually, given just how big and well ventilated those spaces are. Again, this is the long-range airborne transmission risk. So with that, I'll conclude and point you to my website if you're interested in the papers or maybe seeing the app. I did last summer create a massive online course on physics of COVID-19 transmission. It's self-paced. It's still available now because I actually also produce MOOCs on fluid mechanics and other topics. So I thought that was something I could contribute. And I'll just finish by saying that some of the videos from those lectures are on YouTube and they haven't been taken down, despite the fact that they do contain medical misinformation. Thank you.
All right, Martin, thank you so much. That is so great to answer questions on many minds. We appreciate very much that correct information in the face of misinformation.
Yeah, right.
So I have a question. Very interesting talk, and thank you. Have you looked at airplanes?
Yes. So actually, in our app, you can pull down airplane as one of the presets. That actually caused Boeing to reach out to me because we originally put Boeing 737 because we use those numbers. And I learned a lot more about airplanes from that. And what I learned, in fact, is that airplanes are incredibly safe, actually. Besides the fact that they have very high air change rates, they've really engineered the ventilation down to the seat almost. So in fact, if you look at a cross section of an airplane, the air is being circulated essentially straight down past each person into the floor through a HEPA filter and then back out above the luggage compartment. And it's done so with such a high rate, about a 1 to 2 minute air change of all the air around you. And also an airplane, you're typically facing forward, not looking right at another person. So even though your neighbor's pretty close, you're not facing them. So if you think of those respiratory jets that I showed you, imagine they're being swept away very quickly into the floor and through a HEPA filter. So it turns out airplanes are extremely safe when the ventilation is running as normal. Now, where you have a temporary risk, which by the way can be detected by carbon dioxide as well, and you can feel it, is when the plane stops and everybody's standing trying to get off the plane, everybody's bumping into each other and the ventilation has been turned off. You can feel it getting hot, you fear the air getting stuffy. That's actually the most dangerous point on the plane. And it turns out also that you probably have much higher risk at other parts of your journey, like in the taxi cab, or other on the bus than you do actually on the airplane.
Thank you.
Thanks. So we have one question from Judah Rosner, which says, how much difference is there in transmission between wearing a mask that covers your nose and mouth versus one that is only covering your mouth?
Yes, I think that can be significant. So I don't want to overstate the value of masks. There's a lot of debate over that, obviously, and it's clear you can have extremely well-fitting masks, you can have poorly fitting masks. As you saw in the movies I just showed you, the nose, nasal breathing does not provide that much momentum to the fluid. So basically, it does tend to contain the infectious air closer to you, and then it does typically tend to rise in most indoor spaces and then get mixed. On the other hand, so at least you're cutting down, by covering the mouth, you are cutting some of that short range transmission, especially if you're speaking. On the other hand, some amount of filtration is really helpful, actually, because even if you're filtering, say, only 30% or letting 30% of the droplets get through in the aerosol range, which is not particularly good mask, and maybe there's some leakage going on too, that number gets squared if everyone's wearing a mask. So 30% squared is basically 10%. So that's almost a 10 times factor of improvement, in sort of lowering that transmission rate. So I think we don't want to overstate that the effectiveness of masks, and it varies a lot, especially in terms of the fit and how you wear it and the type of material. And there's a lot of debate on that. But there's no doubt that it's helpful. And it's helpful in two ways. There's some filtration, and there's also that blocking of the momentum of the fluid, which helps with short range transmission. I will say, though, that 6 foot distancing with masks has very little scientific justification, which I hope was clear to you from the movies that I showed.
Thanks.
Martin, this is Eric. That was a great talk. I have a couple of questions. The first is when you showed some of your calculations, you designated the space below and above the calculated lines into safe and unsafe. Can you give me some sort of indication of what that means in terms of infection probability? Is safe
Yes,
0
yes.
and unsafe is not 0?
Yes, no, so of course, I hope you appreciate that, I would not say that, when you cross this line, you suddenly go from a 0%
Yes.
chance of transmission to 100%, absolutely not. In fact, what we want to do is kind of stay far from these lines. We want to be like as far as we can into the safe category. One of the differences between these two plots, in fact, was the risk tolerance. So the epsilon here is in the formula was the risk tolerance. So in fact, like, whatever this bound is, you have to somehow decide, like, what is your risk tolerance? And that's one way I think that my work has contributed a bit here to the conversation, is that previous simulations have somehow predicted a risk, like a probability. And I feel that that's hard to act on, and it kind of hides how the variables enter that calculation. I flip it around. I say, let's just have a certain probability that we're willing to tolerate, 10%, maybe 1%. Like in the case of the elderly here, I say 1%, maybe that's too high, right? But once I have that, then I flip it around. I say, what are the conditions to achieve that probability? So these curves on the left are for 10%, on the right for 1%.
Got it.
And again, there's a lot of error. There's probably a factor of 5 error in, like, the infectiousness or more. And we generally try to be conservative, as I said, in the way we fit and use the guideline, but it's far from perfect. But still, these trends are very important to recognize when making policy, because time matters a lot, size of the space, ventilation, etc.
And so the other question I had, one of the other questions I have is, you mentioned a comparison of classroom to office space.
Yes.
And gave the indication that the classrooms are actually much safer than the office space. Can you comment, or what are the assumptions about the actual spaces?
Yes.
That go into those calculations?
Sure. Well, this, by the way, is actual data. This isn't even assumption, actually. So up until this point, I was showing you, just estimates, if you know the ventilation rates, the size of the room. This is actually directly measuring CO2. And all you need to do to convert it to infection risk is to know basically that CQ, that infectiousness of the air that's being exhaled, but the breathing rate of the individuals, the ventilation rate, all get lumped into the CO2, which is.
And just to clarify, this is one classroom and
one
classroom.
Office. Yeah, no, I'm not aggregating for sure. These are two examples. I will not say that, always one thing is safe, always nothing is not safe, but just. And actually, I can tell you, we work with a team in France, actually, that is really into carbon dioxide monitoring and advising them on that. And they have found, for example, in some of these classrooms in France, they go back to the 1600s in some case, terrible ventilation. The carbon dioxide level just mounts and mounts until they finally open the door and go out to lunch, and then it comes back down, and then it goes up again. And in those cases, those classrooms are very unsafe. And interestingly, we predicted with our model, this is not published, and I'm not sure we could publish it, but we had measurements going on in a classroom where our model is predicting there'd be transmission, and there was an outbreak actually in that school actually the next week. So there's that's just anecdotal. What I'm saying here, though, is that at MIT, where we have modern buildings, high ceilings, high ventilation rates, it just turns out that just the ventilation is very good. These are very healthy buildings, if you will. On the other hand, if you go to like where we put our grad students, which is what this is, they're oftentimes in little cubicles where there's only 2 desks. So it's not a large number of people, but they're sharing a small space actually. And it's not as well ventilated sometimes as the classroom. And so it turns out there actually, we would estimate that the transmission rate is much higher. Also, the CO2 level is much higher. So with only 2 people in the office, we quickly get to about 750 ppm. Whereas in the classroom, and this was, by the way, a socially distanced classroom with lower occupancy, but it barely got above the baseline. It went from 450 to 550. So that's, again, a sign of great ventilation. So I think we have to be very careful not to make general statements. It's another reason that I feel very uncomfortable about public health guidance that says, for example, all restaurants or all classrooms must be at 50% occupancy. And I always want to hear, like, show me the calculation that led to that number. And first of all classrooms and all restaurants are not the same.
In thinking about that, though, if we were really going to carefully monitor every sort of individual space, restaurant space, classroom, office, so on and so forth, what's the minimal amount of data that you would have to make that calculation that someone can do
Yes.
on their space?
Well, so that's where I think the app comes in. So if you're, let's say, a superintendent of schools and you know the typical size and maybe ventilation rates of your rooms, you can see, like, on average, if I put in some of the worst case scenarios, you know, what are my classrooms like, you can see if the risk is tolerable. So I think you can take classes of spaces and, you know, with some knowledge about them, make these predictions. And we tried to make it as simple as possible. And I do think it's possible to make, you know, blanket statements for certain types of spaces. But something I'm advocating for that I think really should be widely implemented is CO2 monitoring. These sensors, by the way, I have not had any grant to work on this or any graduate students. So this is literally myself and another lecturer in applied math and a professor of math. We've been doing this work ourselves. And we bought our own CO2 sensors too. So we are talking about just a few $100s. You can buy a sensor and you put it in the room. And even if you don't have the maybe more sophisticated theory that we have here, even though that's easy enough to implement, like using our app, just seeing how that level changes is very informative. Just to put in perspective, when you get to about 2000 ppm, if you spend a few hours there, you might start to feel a little dizzy, you might detect it. Below that level, it's hard to even be aware that there's a higher CO2 level. And so the safe levels are, you know, somewhere in that range, you might say. But just being aware of that number, I think, is really helpful. It also tells you relatively within a certain set of spaces, like in a building, where are the places to worry about? And it can be surprising. You might think it's the classroom, but actually maybe it's the small office, but in another building, it might be the opposite. So I think CO2 monitoring is such an easy thing. You know, we just gave $1 billion, I guess, or that sort of order of magnitude to the schools to prepare for disease and make them safer. You don't need $1 billion. Like, you know, we can just spend a couple $100 and actually start to implement CO2 monitoring as a simple strategy. And that could then inform decisions about how you spend the $1 billion. Should you increase ventilation? Should you just put in new filters? You know, should you try to open windows more, control occupancy, et cetera? I think the CO2 is a great way to start.
All right, Martin, I think we have to move on.
Thank you, Martin.
Next speaker.
Thank you.
Thank you so much. So important to know what matters and what doesn't matter.
Yes, and I also would say that my criticism of others also applies to myself. As a scientist, I'm not telling you definitively what matters. I'm giving you an argument, a set of data, and I hope that you debate it and are skeptical of everything I'm telling you as well.